Welcome to the Patient Experience of Care, Access to Care, Understanding the Involuntary Discharge and Involuntary Transfer Process. This is being presented by the ESRD Network Program Patient Services Team. The mission of IPRO, the End-Stage Renal Disease Network Program, is to promote health care for all ESRD patients that is safe, effective, efficient, patient-centered, timely, and equitable. The IPRO ESRD Service Network compiles of these areas: Network 6, Network 9, Network 2, and Network 1. Overall, we serve over 125,000 dialysis patients, almost 2,000 dialysis facilities, and 53 transplant centers in our service area. Below, you will see the patient services team, our phone number 516-231-9767, our secure eFax 516-403-5969. Any of these ladies on the screen will be happy to help and guide you through any involuntary discharge or involuntary transfer questions that you may have. National initiatives. In order to improve the patient experience of care, the network helps educate patients and dialysis facility staff about the role of the network in resolving grievance and access to care issues. We provide a focused audit of all grievance and access to care cases. The network's case review responsibilities include investigating and resolving grievances filed with the network and addressing non-grievance access to care cases. Federal regulations at 42 CFR require a dialysis facility to cooperate with the ESRD network designated for its geographic area in fulfilling the terms of the network's current statement of work and to participate in ESRD network activities and to pursue network goals. The role that the network plays in the patient experience of care. The network may assume one or more of the following roles in addressing a grievance filed by an ESRD patient, an individual representing an ESRD patient, or another party. These roles include facilitator, where we mediate concerns raised by patients and facilities, an expert investigator, where we investigate concerns raised by patients, an educator, we provide patients and facilities with tools and resources to improve the patient experience of care, an advocate, for the access to care of all ESRD patients, a referral source where we provide patients and facilities on all sources to report concerns, and we're quality improvement specialists where we support the improvement of facility processes to improve the overall quality of care for all patients. What is access to care? It refers to dialysis patients having permanent and stable access to their dialysis treatments within the continuity of care from an interdisciplinary healthcare team. And why is it important to preserve it? As we all know, dialysis is a life-sustaining treatment for the ESRD community. Without an outpatient facility, patients are forced to dialyze emergently at the hospital, removing regular continuity of care. Mortality rates are increased for patients without access to regular dialysis. Patients go to the hospital expecting immediate treatment or better care without knowing that they will not receive dialysis unless their labs show elevated lab values. Access to care. Upon the receipt of an access to care concern, the network will classify the case as one of the following: an at-risk involuntary discharge, which means there's concerns related to a possible patient discharge, an involuntary discharge, which can be labeled as an immediate or 30-day involuntary discharge. The network continues to monitor the volume of these cases throughout our states. This is when a patient is informed in writing that their treatment will be terminated from their current facility. And there's two types of IVDs, a 30-day termination and an immediate termination. Before considering an IVD, a facility's interdisciplinary team should conduct a thorough assessment of the situation, develop a plan to address any problems or barriers that the patient may be experiencing. Please note that discharging a patient for non-compliance is not an acceptable reason for discharge per the CMS conditions of coverage. Please notify the network prior to discharge of any potential IVD and before a notice is given to a patient. And the facility has a duty to assist the patient with placement. Involuntary transfer. This means that a patient is given written notice that they'll be transferred to an alternative facility. Some reasons for an involuntary transfer are a patient's nephrologist will no longer provide care and they acquire an alternate nephrologist who rounds at a different facility. A patient's facility is no longer in network with their insurance, or the facility can no longer meet the patient's medical needs. How we all win in preventing discharges. Patients will feel respected and will share openly due to a mutual trust. The entire team will have a shared responsibility for a positive patient experience of care, and discharges can be decreased and or prevented, allowing the patient to have a continuity of care when more of a chance of success. Preventing the involuntary discharge of dialysis patients. Below is the dialysis facility involuntary discharge guidelines. This can be found on the ESRD IPRO website, and it will also be linked at the end of our presentation. Please check your organization's process for specific guidance. It can be used as an example and a guide for work that should be documented prior to the consideration of an IVD, and it will also show you the necessary documents that may be adjusted to meet the specific needs of the facility, patient, and the reason for discharge. This is a great guideline. It will also provide you with knowledge regarding involuntary discharges and the transfer policies under the conditions for coverage VTAG 766 through 767. An involuntary discharge or transfer should be rare and preceded by demonstrated efforts on the part of the interdisciplinary team to address the problem in a mutually beneficial way. The facility must have and follow written policies and procedures for involuntary discharges and transfers. The medical director must be informed of and approve any involuntary discharge or transfer of a patient. If a facility involuntarily discharges or transfers a patient for non-payment of fees, there must be evidence in the patient's medical record that the facility staff, for example, billing personnel, financial counselor, the social worker, made good faith efforts to help the patient resolve the non-payment issues. In the event a facility ceases to operate, the governing body must notify CMS, the state survey agency, and the applicable ESRD network. The facility's interdisciplinary team must assist patients to obtain dialysis in another facility. Patients should not be discharged for failure to comply with facility policies unless the violation adversely affects clinical operations. Examples of this are violating facility rules for eating and drinking during dialysis should not warrant an involuntary discharge. Patients should not be discharged for shortened or missed treatments, and verbal threats are also not a reason for a patient to be discharged. And you can also see the VTAGs for the conditions of coverage located on our website and at the end of this presentation. In the event that facility staff members believe that a patient may have to be involuntary discharged, the IDT must reassess the patient with an intent to identify any potential action or plan that could prevent the need to discharge or transfer the patient involuntarily. The reassessment must focus on identifying the root cause of the disruptive or abusive behavior and result in a plan of care aimed at addressing those causes and resolving unacceptable behavior. Evidence must be on file to substantiate that the patient received notification at least 30 days prior to an involuntary discharge or transfer, and that the ESRD network was also notified at that time. An immediate severe threat is considered to be a threat of physical harm. For example, if a patient has a gun or a knife or is making credible threats of physical harm, this would be considered an immediate severe threat. An angry verbal outburst or verbal abuse is not considered to be an immediate severe threat. Document the reassessment, ongoing problems, and efforts made to resolve the problem, and enter these documentation into the patient's medical record. The IDT must reassess the patient to identify underlying issues that may be impacting the patient's behavior and any potential action or plan that could prevent the need to discharge or transfer the patient involuntarily. The plan of care based on the reassessment must be aimed at addressing those causes and resolving the unacceptable behavior and preventing an IVD. Documentation of efforts to address the behavior should be done, and this could be included in the care plan agreement. Staff are expected to assist with placement efforts, including immediate IVDs. This isn't just given a list of other clinics and nephrologists. Good faith efforts should be made to find the closest facility to the patient's residence. Include this documentation in the medical record. Please remember continuity of care and the HIPAA privacy rule does not require patient consent to contact another facility. It does, however, limit the sharing of PHI to just those medical records requested and prohibits you sharing any information obtained through hearsay. Also included is the Decreasing Patient-Provider Conflict, or otherwise known as the DPC Toolkit. It was revised in December 2022. It includes health equity, self-awareness, de-escalation techniques, and suggested safety members. It can also be found at the end of our presentation and is a great resource to use within your facility. Other educational resources that the network provides are Can You Ever Be Discharged from Your Dialysis Clinic, the Second Chance Program, an Access to Care Guide, and the IPRO ESRD educational resources. All of these resources are available on our website, or you can reach out to the network and we're happy to email you a copy. Thank you for taking the time to watch our webinar. If you have any questions, please don't hesitate to reach out to the network. Our telephone number is 516-231-9767. Our toll-free patient number is 1-800-238-3773. Thank you.